onto the spine. This is a young girl who was crossing the road when the police car came zooming past at high speed, and she had a on-scene respiratory arrest. There was CPR delivered to the patient, and they had return of spontaneous circulation, and she came in intubated and underwent this CT scan. Now, when you first look at the CT scan, nothing obvious jumps out at you. You look at all the bones of the spine, they all look okay, the alignment looks fine, there's no obvious fractures. And I showed this scan to a lot of my trainees, senior registrars including, and a lot of them will say, nothing exciting, maybe need an MRI scan to find out what's happening. Otherwise, try and wake her up and see how she is. The one thing that everybody often misses on a scan like this is there is no fracture, that's absolutely right, but the head is no longer connected to the spine. You see the big gap between the foramen magnum and the top of the spine. The last time I looked at an anatomy book, this bit should be connected to that bit. So this patient's actually got craniocervical dislocation, essentially decapitated. So unfortunately, this patient is never going to survive. This is an unsurvivable injury. But just sometimes these kind of things, you don't get taught to look at these things. And certainly, this case was the first time I've ever seen a CT scan of a craniocervical dislocation, because these patients tend to die at the scene. This is the first time I've seen one who's come in alive. So like I said, even 5-6 years down the line as a consultant, you still see things that you never see. And, someone will say to you, do you want to take this to theatre to fix the spine? And the surgical decision is, the easy way out is always yes, because you are less likely to go wrong by saying yes. People are usually more critical if you didn't try than critical if you tried your best but it didn't work. So a lot of the times people end up doing all sorts of operation because they don't want to be criticized for not at least having tried, and that's whether by the colleague or by the patient's family. But if there is no prospect of recovery, then you really should just let the patient die with some dignity. And certainly in this case, there's no reason to operate whatsoever. So the patient went to ICU and had organ donation. Slightly less dramatic to the last one, although still pretty dramatic. This is a jockey who fell off the horses at the race and immediately was quadriplegic and was apneic as well. So had to be intubated, ventilated, brought in to us. As you can see on the CT scan, there's an obvious dislocation between C3 and C4 bone. There's also a fracture into the C2 lamina. And when you scroll to the parasagittal, so you can see the facet joints are no longer lined up. So the facet joint, which should be stacked on top of each other, has jumped forward at that level. So this is a proper bifacet dislocation. Unfortunately, these patients have very poor prognosis in that they are extremely unlikely to recover any of the arms and leg symptoms. And actually, in a high cervical cord injury like this, they're unlikely to recover the breathing either, because the diaphragm, as well as all the intercostal muscles, are all gone because you've lost the phrenic nerve and you've lost the whole thoracic spine, which means you've got no intercostal function. So this patient will be with a tracheostomy on the ventilator for as long as he lives, unfortunately, which also means he'll have a PEG tube for feeding and he'll be forever quadriplegic, whatever you do. Now, that's not to say that you don't operate on him. Although there's no prospect of improving his neurology, you can't leave someone with an unstable spine like this, because you can't leave him bed rested and log road for the rest of his life. So here the surgery is to fix the spine, to stabilize it, mainly for easier nursing care. So the patient can be sat up, they don't need to be log rolled, they don't need to be wearing a collar for months and months and months. And it's just overall, it's much nicer for the patient. And then after the surgery, the rest of it is all about really good nursing care and physiotherapy care. And they should all be transferred to specialized spinal injury rehab units as well. But these are major challenging patients because you are not just treating the spinal cord injury. These patients have multi-organ failure as a result of the spinal cord injury. We've already talked about the ventilatory failure. they all have something called neurogenic shock, which means they've lost their autonomic nervous system, that they become very hypotensive, they become very bradycardic, and they can be so bradycardic that they end up needing either temporary pacing wires or a permanent pacemaker to be inserted. At least for the first week, they're going to need to be on inotropic support for the low blood pressure, partly to perfuse the spinal cord, but partly just to perfuse the rest of the organs. So, you've got cardiovascular failure, you've got ventilatory failure, you've got neurological failure, and because this patient is now bed rested, well, I say bed rested, I mean immobile, they're going to get recurrent infections, they're going to get recurrent chest infections, UTIs, possibly DVTs, PEs, pressure sores, you name it, something will happen. So these patients have multi-organ problems and they're extremely difficult to deal with. But once again, for me, this is part of the reason why I really like neurosurgery and things like this, because you're not just thinking in your box. And it's very easy when you become a doctor, whether you're a medic, surgeon, or whatever, to think just within your own specialty. For something like this, it's very easy to come along as a spine surgeon to say, yep, this patient needs front and back fixation of the neck. I'm going to plate the front, put some screws at the back, and then you've done this, you wash your hands. The rest is intensive care problem. And when they're ready to step off intensive care, or the surgery is done, the rest is therapist and nursing care. And they can go to the medics. The medics can look after the slow heart rate and the recurrent chest infections. It's very easy to do that and not think beyond what you should be doing. Personally, I much prefer a holistic approach to all my patients. I quite like to know that I've sorted out a patient as a whole rather than just one specific organ. So, I want to be involved in all the decision making. I'm not saying I want to be the one putting in the pacemaker, but I want to be involved in the decision making as to whether this patient needs a pacemaker, whether this patient needs a chest drain, or should be on, recurrent courses of antibiotics, or whether actually, given the poor quality of life he's going to have, should we say that the next time he has a chest infection, we shouldn't be giving him antibiotics and we should let him go naturally? Those are very difficult decisions, and you want to be part of all of that for your patient, and that's what makes neurosurgery great, I think. This is what we did in the end, fixed it at the front so you can see relocated it. And when I say relocate, it is just like a Colles fracture. I don't know if you guys have seen Colles fractures, wrist fractures when they come to A&E. So they usually come in a little bit like this, and the way to relocate wrist fractures is you increase the deformity by flexing so that you disimpact the bone fragments. You then put traction, so you pull on it so the fractured bone disengages from one another, and then you extend back into your normal anatomical position. You can imagine the bone coming back and then rejoining. And you do exactly the same thing for neck fractures and neck injuries. What you want to do is to very gently flex that neck a tiny little bit to disimpact the bone that the two facet joints that jumped, and then you pull on the head so that you are distracting across the facet joint, and then you extend the head, you put the facet joint back to where it should be, and that's exactly what we did. And then you open up, you put plate on so they holds in the right place. Ideally, you also put some screws in at the back so that you're fixing it front and back, because the injury is both at the front and at the back. As I said, this patient is quadriplegic. He's never going to stand again. At the most, he'll be transferred into a wheelchair, so he's sat up rather than lying in bed. But he's not really going to be doing anything that will cause major, weight bearing on the neck. Therefore, it's unnecessary to be fixing front and back. So once again, the surgical decision making is based on the individual case in front of you, rather than because the textbook says these 3-column injuries should always be fixed front and back. And if you read, the AO spine manual, it will tell you this injury requires front and back fixation. If this patient is going to walk again, then of course that's what I would do. But if he's never walking again, why subject him to a big operation when you can get away with, this operation took me 45 minutes. If I was to do front and back, including the time to flip him and changing the tube and all the rest of it, you're looking at a 4-hour operation. It's just not necessary. So this is what it looks like when we decompress them intraoperatively. You can see the spinal cord, you can see the dura there, you can see the arachnoid membrane pulsing away, you can see the spinal cord pulsing away. You've done a good decompression, you've relocated the spine nicely, job done, and then you can close. intraoperative ultrasound scan is extremely useful. I do it on a lot of my patients because you get real-time imaging of what the spinal cord looks like or what the brain looks like. If you're taking a brain tumor out in an area that's not superficial and you want to confirm you've definitely taken everything out, an ultrasound scan is actually really useful to check that you've not left anything inside. So I always do ultrasound scans. Another spine injury. This is a young man who was at home. Someone rang the doorbell, so he opened the door. And as he opened the door, the person by the door basically just pushed the gun into his mouth and shot him. And what you can see is a fracture across the odontoid process of C2, across the posterior elements of C2, and you can see the bullet lodging at the back of the skin. That's obviously a horrendous injury, and if you imagine the trajectory coming across here, it would have gone through bone, gone through spinal cord, gone through bone again, and then through the soft tissue. So once again, this patient is completely quadriplegic, and there is absolutely no chance that this spinal cord will ever heal. So actually, there is no surgery required in this case. You may do a very small operation just to remove the bullet and give this bit of the wound a little washout and close, but certainly there is nothing to be done for the spine itself. There's nothing you can do for the spinal cord injury. And actually, this is a pure bony injury. It's not a ligamentous injury, it's a bony injury. And all bony injuries will heal by themselves. If you leave this for long enough, the bones will fuse and everything will be fine. So there's actually no need to fix the spine at all. So in fact, we didn't do anything whatsoever. We didn't even operate to remove the bullet. We just left all of this and allowed this to heal by itself. I guess even more interesting when you have polytrauma. So I've been showing you isolated head injury, isolated spine injury. But this is a patient who was hit by a car at a high-speed road traffic accident. And firstly, you can see the depressed skull fracture of the temporal bone and the frontal bone displacing into the orbit itself. You can see some traumatic subarachnoid hemorrhage and generally slightly swollen brain around there. Big hematoma just outside the skull. That obviously is less of an issue. And then if you look at the spine, once again, a horrific dislocation of the cervical spine and also multiple fractures in the lumbar spine, although these are what we call compression fractures, which are all stable, so nothing needs to be done for these. So these are the least of his worries. And then when you look at the lung, firstly, big pneumothorax. Can you see that? The lung completely collapsed down with a big pneumothorax. So this patient needs a chest drain, ASAP. This is about to become a tension. And then when you look at the spleen, which is down here, you can see laceration to the spleen, which is the hypodense or dark area around there. You can see the air in the subcutaneous tissue, which is surgical emphysema. And I don't know if you can just about see a rim of slightly grayish substance around the spleen. That's the hematoma. So this patient also got splenic laceration. That's a grade 4 splenic laceration. So you see polytrauma patient, and they're difficult because all of these injuries are important. All of these injuries alone will give life-changing consequences or even death. How do you prioritize what needs to be done first? The pneumothorax obviously needs to be relieved, and that's a relatively quick chest drain. If this spleen is still bleeding, you may decide the patient needs to go down to intervention radiology to get it embolized, or they may need a laparotomy and have a splenectomy. That decision obviously comes from the general surgeon along with the radiologist. And that's important because if the patient's still bleeding, then there is no point treating the brain or the spine because they're going to die from the hemorrhage. But at the same time, if you say to a general surgeon, actually, you know what, with this spinal injury and with this brain injury, this patient's not going to survive anyway, the general surgeon might then say, well, in that case, what's the point of treating the spleen? Maybe we should just stop now and not do anything. So sometimes it can be very difficult to decide what's the right thing to do. So where I work at St. Mary's Hospital, we've got a dedicated major trauma theatre, which is kept empty all the time with a team who's on standby constantly, only to be used in these kind of circumstances. And what happens is this patient will go straight into theatre, and the operating theatre is designed to be big enough to have 3 teams operating simultaneously. So I can be opening up the head, assuming this patient needs, say, a decompression or cardiac evacuation. I can be doing a craniotomy whilst a surgeon is putting a chest drain in and another surgeon opening up the abdomen to do the splenectomy. All of this can happen simultaneously. So that's the ideal situation if you're in a major trauma center, but that may not always be possible, in which case you need very good discussion with all the different consultants in the different teams to decide what is the priority, what needs to be done first. These are very interesting cases. But enough about trauma. I think we should move on and talk about something else. Have a quick drink first. So this is a young man who went to bed, but his parents could not wake him up, and so called for an ambulance. And actually, when he came in, he was GCS3 with a fixed dilated pupil on the left-hand side. And this is a plain CT head scan. So once again, you can see acute blood, this time rather than on the surface of the brain, which is what we saw with the acute subdural, this is inside the brain. So this is an intraparenchymal or intracerebral hemorrhage. Now, in elderly people, you might say this is high blood pressure, this is warfarin with roxaban, whatever. In a 23-year-old, they're unlikely to be on those drugs, unlikely to be hypertensive. So this is probably a spontaneous hemorrhage secondary to a vascular abnormality. Now, you can take this straight to theatre and operate. This, in fact, was a case when I was a registrar in Bristol. So you could look at this with a patient with fixed dilated pupils, rush the patient straight up to theatre, do your craniotomy and take the clot out. But what you don't know is whether there's an aneurysm or an AVM. And the last thing you need, especially if you're by yourself in the middle of the night as a registrar, is to open up a craniotomy, see a big AVM in front of you, literally shit your pants, pardon my English, because you have no idea what to do with it, and you don't have any support next to you within the next 20, 30 minutes. So always get a CT angiogram first before you do anything else. And even without knowing any anatomy, you can see there's a big difference between the two sides, the asymmetry between the two sides. But there's obviously a lot more vessels on the side with the hematoma. And this is what it looks like after I did the craniotomy and opened the dura. Firstly, the brain is very rounded like a ball, so it's very swollen. Something is pushing the brain up, so that's a bad sign. The second thing to notice is obviously this abnormality here. These are little flow aneurysms within the nidus of an arterial venous malformation. And the problem in AVM is that you've got arteries going directly into veins without the intervening capillary bed. So you've got high pressure oxygenated blood going straight into your veins. And that's where the problem is. Oops, sorry. The wrong button. And can you see the little bruise on the surface of the brain there? That's where the hematoma is on the scan. So the operation here is to make a little cut on the brain here. It's what we call a corticotomy. So you do the corticotomy, get some of this hematoma out, relax the brain down. That probably is all you need to do in the acute situation to save the patient's life. If you want, you can then proceed to resect the AVM. That actually is no longer recommended because if you have a look at this, the AVM is actually quite complicated. You need to work out which are the arteries going into the AVM, which are the veins coming out of the AVM, what are you allowed to cut, what are you not allowed to cut, in what order do you have to cut them. There's a lot of planning involved to remove an AVM, and to do this without going through all of the thought process in the middle of the night really is not recommended. So nowadays you would just take the clot out and close. When I took this to theatre, I was told by my consultant to remove the AVM because it's right on the surface. I'm sure you can do it. It's very easy. There was no suggestion that he was coming in, obviously, to help me. Once again, that would not be allowed nowadays. Things have changed quite dramatically, you might like to hear. So it's much better support for the trainees nowadays. But the interesting thing about AVM surgery is you have to take all the arteries before you take the veins. Because if you cut the veins, but the artery is still supplying blood into the AVM, but you've removed the outflow, then all that happens is these aneurysms in the middle will just get bigger and bigger, and at some point they'll all blow in front of you, and then the patient will die on table. So it's really important to find all the arteries and take them. And you might think these red things are the arteries. Actually, these are all arterialized veins. These are oxygenated blood in the veins. And without the CTA, there's absolutely no way you can tell whether this is a vein or an artery. That's why it's so important to have the angiogram, study it really carefully, work out that this is the artery that's coming into the nidus, this is the nidus, and then this is the arterial phase. There will be a venous phase that will show where the veins come out of the nidus, so you know what you're allowed to cut and what you're not allowed to cut initially. It's really important. And once again, this is what makes neurosurgery, I think, very interesting And I would use a simple example. If you were to take let's say someone's perforated a bit of small bowel, and obviously peritonitic, have to go straight to theatre. I'm not trying to say that operation is easy. Certainly, I can't do the operation. So hands down to those who can. But the operation is going there. Find the perforation. Define a margin of bowel that's going to come out with it, dissect out the mesentery around it, make sure that you tie off all the supplying vessels, cut all of them, that bit of bowel comes out, and then you have to do a very careful anastomosis or defunctional colostomy, whatever it is required, loop ileostomy probably. But the procedure is pretty set in stone. What you do, you don't really have to know which is the artery coming in, which is the vein coming out. Am I allowed to cut this? Am I allowed to cut that? Because actually, you are tying all of it off. You're cutting everything that you're taking out anyway. And in the worst case scenario, if you really can't find the perforation, you just take all the bowel out of the abdomen, which is what they do anyway. They take everything out, they search every inch of it, make sure they don't miss anything. You can't really do that with the brain. You can't really say, I can't find this brain abscess, or I can't find this brain tumor. Let's just take the brain out, find it, and then push it all back in again. It doesn't quite work like that. So there's a lot of thinking and planning beforehand. Hence my comment at the beginning, the technical aspect of neurosurgery, actually I can teach a monkey to do it. It's the decision of whether to do it in the first place, and what to do, and how to approach it. That's difficult, and that's the important bit. Moving on slightly, this is a patient with a very large tumor, as you can see, massive meningioma this is. So this patient presented with, as you can imagine, headache, papilledema, so blurred vision. It's hard to know whether the blurred vision is due to the occipital lobe, so the primary visual cortex, being affected, or whether it is purely papilledema. Because he was quite confused, it wasn't possible to do visual fields and see if he's got cortical blindness and whether he's got hemianopia or anything like that. So examination wasn't possible. But I think it doesn't really matter. You know where the problem is. Now, once again, this obviously needs surgery, but the surgical planning is difficult in this case, mainly because of this black triangular thing here. This is part of your superior sagittal sinus, which is a venous channel that runs between the two layers of the dura. So the problem with the sinus is it's not actually a blood vessel. So if you've got a blood vessel, even with the biggest blood vessel, let's say you're dealing with a ruptured AAA, you can put big clamps across it and stop the bleeding temporarily. Of course, there's a time limit to that because everything will become ischemic, but you can temporarily stop the bleeding whilst you're doing a repair job. With a dural sinus, it's not actually a vessel, it's just a channel within two leaves of dura. You cannot put a clamp across it. So if you end up injuring this sinus during surgery, it will keep bleeding until you manage to repair it. And it is much harder than you think to repair dural sinus. So preparing, thinking about how you're going to do your craniotomy, make sure that when you lift the bone off, or when you're cutting the bone, you don't cut the sinus, you don't tear the sinus when you lift the bone off, and when you're removing the tumor, you dissect it off the sinus very carefully. And also, on the deep end, this is the corpus callosum. You need to make sure that you don't injure the corpus callosum as you're dissecting there. You're very close to the sensory cortex. The motor cortex is just there. Obviously, visual cortex, as I already said, is somewhere here. So all these things you have to be really careful of. You don't want to damage anything more than is already damaged. You want the patient to wake up exactly how they were when they go to sleep. Hopefully better, but you can't always expect a miracle straight away, but at least no worse than before they go to bed, but they go to sleep under the GA. And the other thing to quickly say about neurosurgery is there's a lot of people who think that most neurosurgery patients don't do very well. They're either dead or they walk into hospital and they come out in a bed because they can't walk anymore. I'm not saying it doesn't happen. There are certainly patients who are like that. The majority of patients are no longer like that, especially the elective cases like tumor cases. If any of my elective patient is worse than preoperatively, I would be extremely upset. I don't do an operation to make people worse. I do it because I think they'll get better. And if I don't think they're going to get better from my operation, I don't do the operation. I tell them that actually you're not going to get better. There's no reason to do the operation. Emergencies are slightly different because the damage is already done. So in the trauma cases I've shown you, the primary injuries already happened. Whatever you do, you can't reverse that. So what you're doing is preventing secondary injury. So they may not have a very good outcome if that's beyond your control. But these elective cases are within your control, and they should all leave hospital better than they came in. Here's another example of a meningioma. This time a little one just at the base of the anterior cranial fossa. But if you look carefully, it's not just in the brain. It actually comes through the floor of the skull base into the nose. So this meningioma actually extends all the way down here. So this is a joint operation that I did with the ENT surgeon. So we had an ENT surgeon doing an endoscopic nasal resection of this tumor coming up this way, and I opened up at the top and basically removed this bit, and we joined each other at the hole that was at the skull base, and then we repaired it. I repaired it from the top with a bit of pericranium that I harvested when I turned the scalp flap, and he repaired it from the bottom with the nasal septal flap. So we covered the top and the bottom, and that's mainly to make sure that CSF doesn't leak through the nose and the patient ends up with meningitis. But that's a joint operation. And once again, that's why I like neurosurgery, especially actually any surgery, because you often do joint surgery with other specialties, and that's a really nice thing to do. This is a patient with a low-grade glioma, and this is just to show you the advances in technology. In the old days, you have had a CT scan that actually looks about normal. You have an MRI scan that shows you this kind of slightly dark area. You're not too sure what it is. You think it's probably a low-grade glioma. Someone might tell you it could be a stroke. You end up taking them to theatre to do a biopsy to confirm what it is. Nowadays, you can get MR spectroscopy. With this spectroscopy, you get various peaks and troughs, as you can see. The main one to look out for in this case is the choline peak and the NAA peak. These are kind of breakdown products of neuro tissue, and so in a glioblastoma, so a high-grade tumor, you won't see an NAA peak because there's no normal neurotissue there. It's all abnormal. So in this particular case, the high choline peak suggesting that there is malignancy, along with the high NAA peak means that it's a low-grade glioma. And that's a very simple interpretation. It's much more complicated than that, beyond my own understanding, to be honest. But this really helps you decide what you're dealing with. And also, we know that low-grade tumors can transform into high-grade tumors. And what you don't want to do is end up doing a biopsy of a bit that hasn't transformed and miss the bit next to it that has transformed, and then labeling this as a low-grade tumor, and actually you're dealing with a higher grade and end up giving the patient the wrong treatment. So with the MR spectroscopy, they can measure these peaks in various points of this tumor, and if they pick them at a point where it's showing up as higher grade, that's where you're going to do your biopsy. And then we can set up an intraoperative navigation so that we make sure our biopsy needle is exactly that point, and we biopsy that bit that the scan tells us has a higher grade tumor within it, and hopefully the histologist will agree and will give the correct treatment to the patient. So technology, applying that to your surgery is really, really important. This is the high-grade glioma that I was telling you about, a glioblastoma multiforme, or grade 4 GBM, is what we call it. You can see the difference. This enhances with contrast. It's got areas of necrosis, which is why it looks like fluid, hence it's dark or hypodense. And it's very irregular. It's very aggressive. There's edema surrounding it. It's a large temporal GBM, very horrible prognosis. If you do nothing in a patient diagnosed with GBM, the prognosis is about 6 weeks. If you do maximal surgical resection, but you don't give them any adjuvant therapy, the prognosis is still around 6 weeks. So surgery alone actually doesn't change anything at all. It's surgery with chemotherapy, with radiotherapy, that gives these people roughly 18 to 24 months prognosis. It's still not great, but it's much better than the 6 weeks. It gives them time to, say goodbye to family, friends, to deal with any, unfinished business, and the patient are really happy to have that, extra time given to them. But the important thing here is the adjuvant therapy. And the problem with adjuvant therapy is patients can't tolerate it if they don't have a good performance status. So if you operate on this patient, didn't do a very good job, and the patient wakes up paralyzed, or the patient wakes up unable to communicate at all, they will no longer qualify for the adjuvant therapy. So what you've done then is taken a patient without any neurological deficits and the life expectancy of 6 weeks and converted that person to someone disabled in a wheelchair with a life expectancy of 6 weeks. So you actually make things significantly worse. So if you ever operate on a GBM, you want to achieve maximum resection for good prognosis, but more importantly, you must not give the patient any neuro disability, because that is really a life sentence if you do that. And so tumor surgery is actually quite difficult to do a very good job of, and that's why you need all kind of technology to help you to make sure you don't dissect beyond the margin of the tumor. Back to meningiomas, which is what I showed you earlier on. I showed you the big one at the back. This is one at the front. This is mainly to show you how meningioma surgery can be just as tricky as the GBM surgery. Meningioma, 99% of the time is benign. Usually there's a very nice plane between the tumor and the brain. So, you get a microscope in, you can find the arachnoid plane, you dissect around it, and then, you can take the tumor out without injuring the brain itself. So from that point of view, that side of it is easier, if you like, than the GBM. You're less likely to cause damage to the patient. However, if you look very carefully, can you see this swelling over here? This bit here is the bone. And the skull bone here is obviously much thicker than the skull bone over there. So this meningioma actually has invaded the skull. And this person's actually got what we call an osseous meningioma as well. So if you're resecting this meningioma and you don't remove this bit of bone at the same time, it will just all grow back again. So it's really important in this case to make sure that the skull, the abnormal skull, which goes from about there all the way around to there, is removed at the same time as the tumor. Now, what you don't want is do all of this and leave the patient with a big hole on the head. What we used to do when I was training is you do all of that operation, and then you go to the orthopedic theater, you steal some cement from the hip replacement cupboard, you come back, and then what you do is you get a piece of paper, you put it on the patient's head, you draw the defect on your piece of paper, you then mold the cement onto what you've drawn, and then as it cools down and hardens, you plate it onto the head. And that's how we used to do an on-table cranioplasty or something like this. Actually, it was very creative and it was really good fun. Whether the patient gets the best cosmetic result obviously depends on the person doing it, but actually it wasn't a bad idea. Nowadays, obviously, you don't have to do that. You still can, no one's going to stop you from doing it, but you don't have to do that. What you can do is you get a bony window, you mark what's abnormal, as you can see, you mark the resection margins, and then you send this 3D model with the resection margin marked out to the company, and you say to them, this is what I want to remove. What they then do is they create a cutting guide, which is exactly what you've marked out, that you can then screw onto the patient's head at the beginning of the operation, after you open up the scalp, obviously. You then drill off all the bone that's within your cutting guide, because that's what you've marked as abnormal. And they would have pre-printed, 3D printed a cranioplasty, either with PEEK or titanium or whatever material you've chosen, that will fit perfectly into the defect. And this is what we've done with the patient. So this is a PEEK cranioplasty that we've pre-designed with a cutting guide that fitted exactly what we've cut out. And that's only possible with 3D printing and a cutting guide, because otherwise you end up drilling a bit of bone that you think is what you marked out, and then the cranioplasty doesn't fit because actually you didn't drill what you marked originally on the model. So this is how you can use advancing technology to your benefit, and it's really, really useful. And the patient has a very good cosmetic outcome and complete resection of the tumor as well. On the same theme of tumors, this is down in the spine. This is showing you how spinal tumors can react. This is a horrible sarcoma that you're seeing involving the L2 vertebra, and you can see a massive soft tissue component in the spinal canal. And on the axial scan, you can see the whole spinal canal being invaded by the tumor. You can't see where the caudate equina nerve roots are, and they're probably all squashed somewhere in that little cleft there. And you can see that the tumor exits the spine through the foramen and invades into, firstly, the facet joint, secondly, the paraspinal muscles, and also moving forward and right up against the descending aorta. So this is a really horrible tumor. And sometimes these sarcomas and other types of spinal tumors can keep growing, and they can be attached to the pleura, they can invade the pleura and be attached to the lung, they may be stuck onto a bit of bowel. So these tumors, once again, need multiple disciplines in theatre together to operate on. One person is not going to be able to do all of that. If you look at the corona, you can see this tumor right up against that kidney. And, I can't remember if this is invading the kidney. If this invaded the kidney, then you're going to need a urologist to come and help you do a nephrectomy, and you need a general surgeon to help you do your colectomy. You may need a vascular surgeon to help you peel it off the aorta. And obviously you need a spine surgeon to remove all of this tumor and fix all of this with some metal work. You probably need a big bone graft to fit in here or some metal cage. And then the big hole that you've now created in the soft tissue plane, because you've taken all of this muscle with you. Remember, with sarcoma, you have to do it on block resection. You can't cut into it because you'll seed everywhere and you get lots of metastases. So you have to take everything out in one big chunk, which means all of this muscle here and the skin and the fat tissue, all of this will have to be all cut out in one big cube. And that big hole you've created now needs to be filled. So the plastic surgeon needs to come and they'll need to take some vascularized pedicled, muscular graft, probably gastrocnemius, to plug the hole, anastomose the muscle onto either the axillary artery, by shunting it up here, or onto one of the branches of the descending aorta, and then some form of skin graft or a free flap that also needs an anastomosis. So you can see the number of surgeons required to do an operation like this. This particular operation took 27 hours in total between all the different disciplines. And this is what it looks like intraoperatively. You can see this is the front where the vertebral body was. It's now replaced by an expandable metal cage. The back, the lamina, everything's completely resected along with the pedicles. You can see there's actually no bone around this central dura at all. This is the dura. The nerve roots have been divided, and there's a chorda equina running in the middle, and then the metal screws and rods at the back to fix everything. But this is just the spinal part of the operation, and I haven't shown you what happened inside the abdominal cavity and the work the plastic surgeon has to do to fill everything up again. A massive, massive operation, but very interesting operation. So that's tumor in a nutshell. Okay, so moving on to something else that we see a lot of. This is my other subspecialty interest. So apart from neurotrauma, my other interest is hydrocephalus and CSF disorders. This is a patient with a colloid cyst. You can see that cyst causing obstructive hydrocephalus. So these are very dilated lateral ventricles. And these patients with obstructive hydrocephalus, they don't go off slowly, they suddenly deteriorate and go. So this particular patient came in with severe headaches, a little bit drowsy. I was still able to get history of him in A&E. I turned around to say to the A&E nurse, get this patient ready, we need to get him straight up to theatre as soon as possible. And as I turned back round, and that took me, 20 seconds to say that sentence, when I turned back round, the patient was GCS3, fixed dilated pupils. This is how quickly they deteriorate. I ended up having to bring the drill and the 2 EVDs, external ventricular drains, from theatre down to A&E and put the drains in A&E to drain off the CSF because we didn't have enough time to get the patient up to the operating room. So I did the operation down in A&E. This is how quickly these patients can deteriorate. When we say it's an emergency, we really mean it. It's not emergency in the next hour, it's emergency in the last hour. It's too late already. Now, once you relieve the hydrocephalus, the longer-term solution is to remove the colloid cyst, and this is an endoscopic colloid cyst resection that I've done. So what we've done is we've put an endoscope into the lateral ventricle in this top left picture. What you're seeing is choroid plexus here, which is obviously the substance that produces CSF. This is a septal vein, this is the septum pellucidum over here, this is the foramen of Monro, and this is the fornix that's involved in your short-term memory. Obviously the head of the caudate will be somewhere here, the thalamus will be somewhere down here. And this grayish thing is the colloid cyst, which is obstructing the foramen of Monro, which is why the CSF can't get from this lateral ventricle into the third ventricle. So on the next picture here, we've made a little cut on the surface of the colloid cyst, and we're using little grabbers to pull out the material inside. This is what we call colloid, which is just a really proteinaceous fluid, to be honest. It's quite thick. Sometimes it doesn't pull out, and you have to stick the whole endoscope in there to suck it out. Sometimes they are solid bits that you can pull out with some grabbers, like I'm doing. And then you basically remove the whole cyst, so you open up this foramen of Monro, and you go into the third ventricle. This is a view of the third ventricle. What you're seeing here are the mammillary bodies, which is basically the top of your brainstem here. Right at the front somewhere there will be your pituitary fossa. In between here is a thin membrane, which is where we're going to do our third ventriculostomy. The third ventriculostomy is basically making a hole in this membrane so that we divert CSF from the third ventricle into the cistern or the CSF space in front of the brainstem, so that it bypasses the aqueduct of Sylvius and doesn't have to go into the fourth ventricle. And this is something you would do if there was an obstruction in the aqueduct that was blocking the flow between the third and the fourth ventricle. You don't have to do this in the cholecyst operation. If you've resected the whole cholecyst, then you can leave it as that. The problem with this particular cholecyst was that it was sitting quite far back, so we managed to remove the portion that was obstructing the foramen of Monro, but there was actually another bit that was stopping CSF going to the back of the third ventricle down the aqueduct. So we had to divert the CSF as well. So what you're seeing is a diathermy probe that's poking a hole through the membrane and then inflating a balloon to make that hole as big as we can. And then with some luck, this is a video of what it looks like. So this is, let me turn this off. So this is through the stoma that we've created. This is the basilar artery. These are perforators to the pons. This bigger vessel here is the superior cerebellar artery, and just behind all these vessels is the brainstem itself. You can just catch a glimpse of it. These are thin arachnoid membranes that we have opened up. And then as we're just withdrawing the endoscope back in the third ventricle. So that's the view once you've made a hole. So you can imagine that white thing here, that is the clivus vein. So the pituitary gland is sitting here. This is the basilar artery. So the gap between that thing and the basilar artery, which usually measures somewhere between 3 and 5 millimeters, is where you make the hole. So make sure you make the hole in the right place. Right. By the way, do stop me if you think I'm going on a bit too much. I can always stop. I've got loads of cases. This is a young man with a Chiari malformation, which is basically descent of the cerebellar tonsils, which is this part, beyond the foramen magnum into the top of the neck. So if you imagine, this is the foramen magnum here. This is the C1 bone. You can see the tip of the cerebellum is actually behind C1. So that bit of cerebellum has sunken down. It's a type of herniation, to be honest, but it's a Chiari malformation. And because you can see the CSF has been obstructed across here, the CSF can't flow down the spine as usual. It all comes within the spinal cord, and you end up with a big syrinx. So this is syringomyelia. So all the fluid is collecting within the spinal cord itself. And the problem here is the syrinx ascends all the way up, and you can see a bit of CSF within the brainstem. So this is actually syringobulbia, and hence the patient presented with bulbar symptoms of dysphagia and hoarse voice. So the operation here is the foramen magnum decompression. What that means is removing a little bit of the occipital bone here and a little bit of the C1 bone here to open up the foramen magnum, so there's more space to accommodate this bit of brain that's descended. So we've done the FMD, and if you have a look here, a bit of bone is missing, the C1 is missing, and there's now a lot of space across here. You can see CSF, and again, you can see the syrinx has shrunken right down. It's never going to disappear completely, but the spinal cord at least is a normal size and normal shape, and there is no more fluid within the brainstem. This patient had complete resolution of all his symptoms, and I've seen him for 3 years now. He's absolutely fine, doing really well. So really satisfying, and that's once again a nice thing about surgery, not just neurosurgery, that you can get really good outcomes, and you can see a difference in the patient. And this is one of the examples how you can make a huge difference to someone who was having recurrent aspiration pneumonias and could hardly speak, to someone who's now back to normal life, normal function. Children present with slightly different things. These are different examples of cranial synostosis. So these are babies with abnormal head shapes due to the suture lines fusing too early. So you can see this is what we call trigonocaphy, which is a metopic synostosis. So you've got this very sharp ridge on the forehead. Here you've got scaphocephaly, which is synostosis of the sagittal suture. So you can see the sagittal suture is gone. You can still see the coronal suture. And remember, the bone grow perpendicular to the direction of your suture. So for the sagittal suture, which runs front to back, that governs the bone growing sideways. And because this has fused, the skull can no longer go sideways. That's why it keeps growing front and back. That's why it's got a really long head, like a boat. That's why it's called scaphocephaly. That's Latin for boat head. And then this is a multisutural synostosis. You can see metopic synostosis. There is also sagittal synostosis, and what you can't see is there's also skull-based synostosis, which is why the head is growing upwards as well. So these are, the problem with these patients, not just cosmetically, but also the brain is being limited. It can't grow in certain directions. And so these babies potentially can end up with cognitive impairment, physical impairment, and just generally not reaching their developmental milestones. And so it's quite important to recognize craniosynostosis and operate on these, essentially removing the suture that is in question and potentially also remodeling the skull into the correct shape for the patient. So these are, once again, very, very interesting cases. So here's a child with APEX syndrome, which is basically multi-sutural synostosis, along with fingers that are stuck together syndactyly, polysyndactyly. But if you have a look at his head, you can see this very big forehead here, very sunken mid-face and sunken eyes, and quite a tall head. So we operated on this child, and you can see at the end of the operation, a lovely flat forehead that's curving backwards relatively normally, and we've also brought the orbital bar forward, so the eyes are now sitting in the right place. You can't just flatten the forehead, you have to bring everything forward as well. So we brought the whole orbit forward along with flattening the forehead. So this is a very nice cosmetic outcome, but as I said, more importantly, allows the brain to expand normally and grow normally, and hopefully develop that normally as well. Another pediatric case, this is an extreme case of NF1. As you know, NF1 has lots of signs and symptoms. They have all these neurofibromas, plexiform neurofibroma, they get niche nodules, they get cafe au lait spots, axillary freckling, etc., etc. One of the things they get is sphenoid bone aplasia or dysplasia. And if you compare the bone on the two sides, this is your sphenoid bone, this is the wing of the sphenoid. You don't see it on the other side. What's the problem with that? Well, that is the barrier between your middle cranial fossa and the orbit. And if you don't have it, this happens. Your temporal lobe prolapses into the orbit. Where is the eyeball? That's the eyeball on one side. You can't see the eyeball on the other side because that's been pushed out of the orbit. So this 12-year-old girl presented with a large plexiform neurofibroma over this right eye, but the eye has dropped all the way down to the cheek. And so the operation here is to somehow bring this brain all the way back, create a new physical barrier here, and get the eyeball back into the socket. Easier said than done. But this is a 3D image from inside the skull. Once again, you can see this is the greater ring of sphenoid on one side, and we've lost this greater ring of sphenoid on the other side. And what we've done is we've done a 3D printed titanium plate that we've pre-designed. We've done a craniotomy, opened up endoscopically. I fenestrated the CSF cistern so that the CSF is diverted away from the temporal lobe, and the temporal lobe automatically just shrunk away back into the cranial fossa by itself. We then plated this neosphenoid bone on, and remember we have to leave space medially to allow the carotid artery to come out of here and the optic nerve to go through the optic canal. But that allows us to know that the brain is never going to collapse into orbit again. The plastic surgeon then comes in, debulks the plexiform neurofibroma, and allows the eyeball to drop back into the orbit. So that's the operation done here. This is another similar case, but in a slightly older patient, 22 years old, with neurofibromatosis type 2. So that was type 1 I showed you, this is type 2. And with type 2, patients can get multiple meningiomas. And what this patient's got is hyperostotic bone as a result of meningioma. And you can see, if you compare the two eyes, this eye is sitting much prouder than the other one. And because the orbital volume here is much smaller than this one as a result of thickening of the orbital bone from the meningioma. You can see how thick this bone is. And this is what she used to look like. And over the years, you can see how she has changed because the bone has thickened over time and the eyeball is being pushed out. And this is what she looks like when she was first referred to me. You can see the eyeball completely outside of the orbit. Quite horrible for the patient, actually. And so what did we do? Actually, didn't have to do a craniotomy at all. Opened up like a craniotomy, opened up the skin flap like a craniotomy, dissected all the way down to expose the whole zygoma, and then basically removed the zygoma so I can get to the lateral orbital wall, drilled off the lateral orbital wall here, and then putting a little brain retractor on the eyeball to protect it. I then put the drill at the back of the orbit next to the optic nerve and drill the bone all the way back towards the temporal lobe and drill the roof all the way up to the frontal lobe. And the ENT surgeon came from within the nose and drilled away that medial wall of the orbit. As you can see, there's a bit of bone missing there. And that combination means that the orbital volume has increased and the eyeball can go back into the eye socket. So this is what she looks like before surgery. This is what she looks like after surgery. That she's never going to be back to complete normality, but you have to say that's not a bad result for someone whose eye is completely outside the socket before. And most importantly, she's managing to see again in that eye. So the vision has been retained. Why am I showing you all these cases? Because actually what I really like is joint operation with other surgeons. I mean, there is something to say about being by yourself and having a bit of peace and quiet and doing what you want to do, quietly. But it's actually really nice to have other surgeons in theatre who do things slightly differently or specializes in something different, because you learn a lot from them and you see things that they do and you just think, oh, I never thought of doing it that way before, or I really like that bit of instrument that you're using. What do you use it for? And I can use it for this instead. And then you start broadening your practice and actually improving your own surgical skills. There are so many things that I do this year that is slightly different to last year because of what I've seen other people do. And it's just really, really nice to be part of a big team of people. Last couple of things to show you. This is a baby with a large spinal bifida. This is obviously something that is only done in specialist centers. This is one from when I was a registrar. And what you can see here, and the main reason for showing you, is this is the neural plate. So if you remember back to embryology, we've got a neural plate, which then folds itself, forms a neural fold, and then a neural tube, which then obviously fuses top and bottom where the neural pores are. This is when the neural plate doesn't fold at all, and we call this a placode. And then what you can see, the slightly grayish tissue around there should be the dura, and then you should have a bit of muscle. You can just see there, a bit of fascia, which is a shiny thing. And then you should have skin over it, but none of that has developed because the somite has not developed. And so the surgery here is to prevent CSF leaking out, which means infection can go in. So you just have to somehow get covering over all of this. You're never going to recover the neurology, but it's very important to make sure you don't give this baby meningitis, because if you repair this nicely, yes, they are paralyzed from that point onwards, downwards, but everything above there works perfectly fine. They can have a completely normal life with normal arm function, normal cognition, if you get this bit right. So it's really important to do these things right. And then the last thing to show you, and this is because it's the thing that I like the most, is something that is less acute. I've shown you loads of acute stuff. This is actually something that's much more long-term. This is a patient who presents with a triad of dementia, mobility decline, and urinary incontinence. And for those of you who know, this is a triad for normal pressure hydrocephalus. And you have the CT scan. The problem with NPH is that the CT scan just shows you atrophic brain. The ventricles are a bit big, but that could be because the brain is atrophic. The patient, is elderly. Elderly people tend to be a little bit demented. They tend to be a bit slow with their walking. And because they're slow with their walking, they can't get to the toilet in time, and they may wet themselves. If you walk into a nursing home, that fits the description of 50% of their occupants. So how do you know which one just has really bad Alzheimer's or Parkinson's and which one actually has NPH? The answer is it's very difficult to know, and that's the problem with this condition. In France, which has a smaller population than us, they roughly do about 2,000 VP shunts a year just for this condition. In England, which has a bigger population, we do 300 VP shunts a year for this condition. So either they are over shunting or we are massively under shunting. And given Japan shunts about 3,000 people and Sweden shunts about 1,500 people a year for NPH, I think we are the one getting it wrong. So in the UK, we're not very good at recognizing NPH and giving them the treatment that they need. And there was a study in Sweden that suggested that if you went into a nursing home and you shunted every single occupant in there, obviously not the staff, I mean the people who are living there, regardless of why they're there, a third of them will leave the nursing home completely independently self-caring back home. This is the number of people that we should be shunting that we're not doing it. Let me show you this video. I'll just switch the sound off. This is a man with NPH. He's trying to stand up. We've got Zimmer frame in front of him. This is Mr. Richard Edwards, one of the neurosurgeons in Bristol. He's my mentor who taught me all about NPH. And hence I'm borrowing his video. But you can see this guy really struggling to stand up. This is called retropulsion, where they're falling backwards, very typical of NPH. The test is called the up and go test. And all we want to do is to watch him take a few steps. He can't even stand up properly. This is what happens if you shunt the patient. Without Zimmer frame, stands up, walks around, turns around, comes back, sits down. And this is 1.5 months, so 6 weeks after putting the shunt into him. So you can see the big difference from essentially needing 24-hour care to completely self-caring, not needing any extra support whatsoever. So it's really important we get these things right. And that is the end of my talk. I think I've talked for long enough.
Thank you very much. That was very interesting. There were a lot of things we don't see on placements, and I think this gave us like a really good overview of what is neurosurgery about and the different operations. One of the things I want to ask for, because sometimes on social media I see a lot of people, for example, giving examples on operating on different brain tumors, for example. And they talk a lot about the way they access through the skull. Is there a particular way, or is there a standard, for example, on doing a certain operation, or each case is different and each way you have to, for example, choose a different axis?
You're right, yeah. So each case is different. And it's not just about the surgical approach, how you position the patient, but also what equipment you might want to use. So, once again, like you said, when you look on social media or if you go on, journals and papers, people boast about how, they have obviously intraoperative navigation machine. They have the latest microscope or the exoscope, which is obviously with a 3D TV rather than looking down an eyepiece. You have awake craniotomies, you have intraoperative neurophysiology, you have intraoperative MRI scanners, you do 5-ALA to make the tumor light up with fluorescent light, you can do intraoperative ultrasound, mapping, diffuse tractos, I can't say it properly. You can do tractography with the MRI, so the DTI, to look at all the white matter tracts. There's so many different things that you can do to improve your surgical outcome. But every single thing is trying to make sure that you stay within the tumor and you're not basically cutting something you shouldn't cut. And which method works best really depends on where the tumor is and the nature of the tumor. If you've got a tumor that is in the speech area, then actually an awake craniotomy is the best thing, because you can get a speech and language therapist sitting there talking to a patient, assessing all the different domains of speech and language whilst you operate. Whereas neurophysiology won't be very useful, because neurophysiology is very poor at picking up speech and language action potentials, because it's not just Wernicke's area and Broca's area. You've got the whole arcuate fasciculus. Where do you measure from? But at the same time, if you've got a tumor in the motor area, then actually neurophysiology is fantastic. You can do your MEPs. You don't need an awake craniotomy at all. So you can see it really depends on where the tumor is, and depends on the patient as well. An elderly patient who's a bit confused because of a high-grade tumor is unlikely to stay still if you do an awake craniotomy. So you can't really do that in those patients. Similarly, intraoperative MRI scans is very useful in pediatric tumor, because pediatric tumor really is all about that 100% resection before you send them off for proton beam therapy or whatever it is you decide to do. Whereas in an adult, if you're doing a meningioma, you can see the tissue plane. You're not going to leave anything behind. There is actually no point getting an intraoperative MRI scan, because you know what you've taken out. So you can see everything's different. It's not just about I've got every toy under the sun and therefore my unit is the best.
So one of the, I think, big questions I have to ask, because I think a lot of the participants also are interested in neurosurgery or in surgery in general. What are the things, for example, that you recommend in order, for example, to make our CVs better just to get into neurosurgery, for example?
Yeah, so I think because neurosurgery is such a niche area, if you like, people want to know that you are dedicated to that specialty from the beginning. What we don't want is someone who's been an orthopod for a few years, decided actually I don't like the limbs, I'll go and be a medic for a couple of years. Actually, I don't like prescribing antihypertensives. Let's give it a go as a neurosurgeon. We don't want someone like that because, as I said, actually, when you become a neurosurgeon, I'm not saying it takes over your life, and certainly if you are good at time management, you can have a good, work-life balance still, and certainly, I still enjoy my family life a lot. But you do have to be very dedicated to your work to do a good job of it. And so we want someone who know that they like it, who know that they will put the time and effort into it. We don't want to waste your time, to be honest. We don't want you spending a few years and deciding, actually, this is not for me, I want to go and do something else. And so from a CV point of view, you need to have things on there that proves your commitment to the surgery. So we all know that you need to have some audit projects, maybe hopefully some research publications and some quality improvement projects. Everyone knows about that. But having an audit project on, prescription of, enoxaparin on the renal ward, or the use of oxygen on the respiratory ward is irrelevant to neurosurgery. We want to see an audit about, anticoagulation in a traumatic brain injury. We want to see, a research project on, placebo versus operation for a pec fracture, for example. That kind of thing. Something that is neurosurgically relevant to prove that actually, even from a few years ago, you already think about neurosurgery. It's not that you've tried a bit of everything and then decide that's what you want. So commitment to specialty is what people look for.
Thank you for answering that. You've mentioned commitment is a very important thing, dedication as well. How does that affect work and life balance? I think that's also an important.
Yeah, it is a big issue. I'm not going to lie. For example, I generally I do live quite far away from the hospital, so that's partly my own fault. But I leave my house at about 6:15 in the morning, and I get into work just before 7 o'clock. And I generally stay in the hospital till about 7, half 7, and I get home for around just after 8 o'clock. And that's, Monday to Friday, and on quite a few weekends as well. So, but that's my own choice. I've chosen to spend a lot of my time doing education, doing research work, as well as my clinical work. But some of my colleagues are very different. They will work Monday, Wednesday, Thursday, Friday, but Tuesday is their day off. So they've organized their timetable so that they have their clinics on Mondays and Wednesdays, they're operating on a Friday, and Thursday is their admin day where they get all the paperwork and all the meetings out the way, and they have a day free where they can go and spend time with family. And certainly that is possible. So it's about how much you take on, what you say yes and no to, and that depends on what you like, I guess. So most of us, I would say, actually have quite a good work-life balance. We still enjoy going out and having a laugh. And actually, as a department, I'm quite lucky that all my colleagues are very nice people, and we do tend to go out and have a drink together or have dinner every so often. Sometimes we invite each other round to our own houses, not at the moment with the lockdown, but normally we do actually have quite a good social life.
I think Jasmine asked the question.
Okay. That's it. Would you say that there is a single long-term treatment available to treat hydrocephalus out of shunts, ETV, and ETV with coronary plexus cauterization? So the answer is, once again, it depends on the condition or that's causing the hydrocephalus. So ETV really only works if you've got an obstructive hydrocephalus. Doing an ETV, for example, in normal pressure hydrocephalus doesn't work, and there's lots of papers, lots of people have tried it, and the outcome just isn't great. So if you tailor your treatment correctly, you get really good outcome. Certainly, if you're doing an ETV with the coronary plexus cauterization, personally, I think does make a difference because you are reducing production of CSF. So that does make sense. But if the patient is not a suitable candidate for ETV and they just need a shunt, then actually the shunt it is. And sometimes they want to say it. And actually, even when we say shunt, there are so many different types of shunts out there. Which one do you put in? Do you put a fixed pressure valve, a programmable valve? Do you put in an anti-siphon device or without an anti-siphon device? And anti-siphon device nowadays can be programmable as well. And you can get reservoirs which are sensor reservoirs that allows you to measure ICP externally with a reader without putting a probe into the patient's brain. Do you put all of these things in and cost your hospital about £8,000? Very expensive. But once again, the treatment has to be tailored to the patient in front of you. I can't give you a single answer that fits everything. And actually, that brings me to a point about evidence-based medicine, which is obviously a big thing. We all know about evidence-based medicine, and certainly I read a lot of papers, and I think it's a very good idea to keep yourself up to date. But you always have to remember, not just that the papers may be poorly designed in terms of the study, and the statistics may be actually complete rubbish, which often is the case. But even when you've got the best paper published, you are looking at a paper that is generalizing a treatment across a normal population based on the normal distribution. Your patient may not fit that distribution. Your patient may be one of those in either extreme, and therefore that treatment option may not actually be the best thing. So just because the paper or the book says this is the best treatment, it still may not be the best treatment for that particular patient in front of you. So that's where history and examination and actually knowing your patient becomes so important. Simple spines like degenerative spines, spinal canal stenosis, disc prolapses, that's a bit different because that's pretty straightforward. But anything slightly more complex than that, I don't really think you can make a surgical decision the first time you meet that patient, because you know nothing about that patient. You may have a list of drugs that they take and a list of past medical history, but you don't know what their social life is like, you don't know what their occupation is, you don't know what their personality is, and actually that all plays into it. And I'll give you a really good example. Pec fracture, okay, very simple fracture to the top of the neck. One of the treatment option is a fusion, right? A C1-2 fusion. You put some screws in, you fix a fracture. What's the problem with a C1-2 fusion? Once you fix C1 and C2, they can't turn their head. If they're a bus driver, they've lost their job because they can't turn their head, right? So if you don't think about the occupation, you may have fixed the problem, but you may have given the patient a bigger headache afterwards. You can put these patients in a halo vest. So I don't know if you've all seen the halo vest, but it's a big ring around the head with rods that connects to a vest that they wear. It means you don't have to fix them, but they wear this for 3 months and you allow the fracture to fuse so that they end up with normal range of movement when you remove the halo vest. So that would be a much better treatment for someone who's a bus driver or coach driver, because you retain movement. But if your patient is a criminal who's in prison and they've had this fracture because something's happened in prison, and I'm giving you this example because I had the patient exactly like this, and you put a halo vest on them, what happens is they go back to prison and all the other inmates in the prison will think it's really funny to pull on this halo vest or do pull-ups on it or whatever. And what happens is 2 days later, the patient will come back to you and this halo will have been ripped off the head because some other idiot thinks it's funny. And once again, you end up with a bigger problem. So you have to adjust your treatment according to not just medical history, but also social history as well. It's actually really important. Another question. Yeah. So what is your opinion on Neuralink and brain-computer interfaces in general? That's a very interesting question, actually. I have to say I've not come into contact with this a lot, so I can't give you a very good answer. But I do think that we are heading in that direction. So slightly up one step back from the computer interfaces, we are now starting to use robots in neurosurgery. So we are way behind, say, the urologists who have been using robots for about 13 to 15 years to do prostatectomies and nephrectomies and things like that. We have started using a robot to help us place deep brain stimulators so that we are very accurate. The stimulator is exactly in the subthalamic nucleus that we want, or we use it sometimes for very small tumors and abscesses that needs to be biopsied. But we're talking about a very primitive robot that has an arm that you basically put onto the computer, this is the target on the scan, this is my entry point, and then the computer will move this robot arm to the right place. It doesn't do anything else, it just goes to the right place, and then you put your drill through the robot arm so that you're drilling in exactly the right place to exactly the right depth. So certainly from an accuracy point of view, it's really good. And quite a few units in Switzerland, Germany, and America have started using robots to put screws into the spine as well, just so the screws are never in the wrong place. But once again, this is a very, very primitive version of a robot when you compare to the Da Vinci robot that the urologists and the bariatric surgeons used. And then the next step along from that will be your virtual reality and augmented reality, which we are starting to build into our microscopes, so that we can see, say, the blood vessels superimposed over the tumor, so we know what we are about to find. Or if you're doing an acoustic neuroma, you can superimpose the facial nerve, so you know where you can cut and where you can't cut. But once again, these are very early steps when you compare to computer interface and actually, having artificial intelligence, as it were. We're using it a lot in training, but not really in clinical practice yet. And then I can see another question. Have you ever had to perform a surgery on a rare neurological condition that has no established treatment? Unfortunately, more frequently than you'd like to think. Not necessarily because it's so rare, but because there just isn't very good treatment sometimes. But recently I had a patient who had an anterior cord herniation. So he basically, actually it was a she, sorry. So she presented with what sounded like a spinal cord injury, with kind of a progressive paraparesis of the legs, a progressive numbness with a sensory level. And when we scanned her spinal cord, initially didn't find anything at all. And then we went back for a repeat MRI scan in a 3 Tesla scanner with a myelogram and a twist sequence, so it's not just high definition basically. And what you can see is that the spinal cord actually, rather than being circular, was actually more like a T shape or triangular shape. And basically there was a dural defect at the front of the spinal cord, and the spinal cord has herniated forward and basically trapped a bit like a strangulated hernia as a strangulated spinal cord in the mid-thoracic spine. And that's very rare. I mean, when you look it up in the literature, there aren't, a million case reports. So it's not a very common pathology. So, you take the patient to theatre because you need to do something. You do your laminectomy to expose the dura. You open the dura so you see the spinal cord, and then you're standing there looking at the spinal cord thinking, now how the hell do I pull this thing back into the canal? There's no established way of doing it. You're looking at it thinking, well, I can't just pull on the spinal cord because I'll just make things worse. But in the end, what I did was, luckily, because we're in the thoracic spine, the thoracic spinal nerves don't really do very much. They supply one set of intercostals. You can make do with one less intercostal muscle. So we basically cut the nerve root on either side, and then grab the nerve root with a pair of forceps, and then just wiggle to the spinal cord like that until it basically reduces back into canal, and then slid an artificial dura at the front to cover up the whole loss of tissue glue and stitch everything up at the back again. So it was kind of an improvised operation at the time, and it worked, and the patient recovered okay. So you kind of then wipe your sweat off your forehead and congratulate yourself. But it does happen, and that is one thing I do like about neurosurgery, is a lot of it is a bit of improvisation at the time, with obviously knowledge of what you can and can't do, and what is and isn't safe. But it's nice. I see a couple of other questions. Where do you see neurosurgery in 5 to 10 years? Okay, so certainly when I first started neurosurgery, we didn't even have navigation, or it was just coming in. I can't say we didn't have it, it was just starting. And it was one of those, I remember I put the patient on a table with a brain tumor, and then I pinned the patient with the Mayfield pins to make sure the head is fixed, and I was starting to attach this what we call the tree, which is basically the navigation panel for the camera. And my consultant walks in as well, this old-fashioned consultant. He was like 61 or 62 years old. And he said to me, "Kevin, what are you doing?" And so just setting up the navigation. And then he took out his finger, pointed at the head, because Kevin, the brain is there. So that's about 10 years, maybe about 15 years ago, okay? Now, if you do a brain tumor operation without navigation and something goes wrong and you get taken to court, you have no leg to stand on. It is an accepted gold standard that has to be done. So the next thing that's going to happen is the robot. Because at the moment, if you use a robot to put some screws in, or use a robot to identify the best place for your deep brain stimulator, people will say, oh, that's very fancy, you work in a very rich unit. I bet you any money in 10 years' time, that will be the gold standard. And you put in the screw in the spine without a robot, without navigation, and it hits the spinal cord, you have no leg to stand on. You will not be able to justify doing that operation. But that's where we're going. We're talking about navigation, we talk about robots, we talk about augmented reality. Definitely. The next question is from user, so no name. What areas should medical students be concentrating on extracurricular stuff for our CV portfolio to be pursuing neurosurgery as profession? Okay, so we've talked about the academic side of things in terms of audits, research, and things. The other thing to show commitment to specialty is obviously exactly as what you guys have done, joining societies that are relevant to the specialty, so Neuroscience Society, Neurosurgery Society, doing work experience. When I say work experience, I mean spending, say, a week when you say you don't have any lectures or anything with a neurosurgeon, just shadowing them around, or maybe just a day. If you're a local neurosurgeon doing 24-hour on course, which say I do, I'm always happy for medical students to be shadowing me for the 24-hour period if they want, just to see what it's like going to A&E, going to theatres, or sometimes sitting here giving a talk. I think you want to show that you're doing things as part of your neurosurgery progression. In terms of non-medical things, so things completely outside of medicine altogether, what you want to show are things that prove you have good communication skills, leadership skills, and team working. That's universal to most of medicine, but more specifically to surgery, especially neurosurgery, is also your hand-eye coordination and your fine motor skills. That's quite difficult to prove that you've got when you go to an interview, and someone say, what attributes have you got? And you want to tell them that, well, I have, my hands don't shake, and I'm very good at my hand-eye coordination. You have to think of good examples. The example I used, which may or may not be a good example, is that I play the violin. And I say that that's a very good example because I am looking at the score, the music scores, whilst one of my hand is pressing on the strings without my eyes looking at it, and my other hand doing something completely different, which is using the bow. But that makes me ambidextrous, able to do two different things simultaneously, and without needing my eyes to look at my hands. And I say that is a very good way to prove that you have got good coordination. And I'm not saying you should all go and learn the violin, but think of something you do that has similar qualities. But if you are belonging to a club or society or a sports team, if you are the captain or the leader or the chairman, those are all really useful things to prove that you are able to take on such a role. And then the next question I got here is, what do you see any works with prosthetics in the close future? If so, how? And do you see any work in prosthetics? Oh, sorry, it's the same question. Oh, you've retyped it, sorry. Okay, do you see any works in prosthetics in the close future? When you say prosthetics, what do you mean by prosthetics exactly? Because, we do have 3D printed vertebrae, and we do 3D printed cranioplasties already. So that's a type of prosthetic. I know it doesn't move, it's not a joint, but it's still a type of prosthetic. Like I said, we do 3D printed cranioplasties already, which is a big jump from what we used to do, as I've already described to you. The other things that we do that we never used to do in terms of, I guess, is it really prosthesis? It's not really prosthesis, but you may have already read about that case where a guy with spinal cord injury went to have this stem cell injected into the spinal cord. This is in Poland, and recovered function. I don't know if you read about this. This was the UCL team working with a Polish surgeon. And basically, it's a guy with a penetrating injury and a really clean cut to the spinal cord. And what they did was harvested stem cells from the olfactory groove and took a neural nerve as a graft, went in there and basically put the serial nerve as a graft between the two ends of the spinal cord, and then injected the cultured stem cells from the olfactory groove around the area. And actually, the patient gradually started to move their legs and started to walk again. Now, it's the only case ever reported, and just like any literature, it can be a coincidence. It may be that this guy was going to recover anyway. Who knows? But that's the kind of advance we're looking at. I guess it's not really a prosthetic, but it's that kind of thing. What else do we have here? Okay, yeah, exactly. So potentially start moving things, which is, I think it's really good. The problem is it doesn't work for all kinds of spinal cord injury. You have to have a really clean cut. If you've just got a really horrible bruise to the spinal cord, or unfortunately if you have a blast injury or gunshot injury where the spinal cord's completely trashed and mangled, then there's nothing you can do to repair that, really. Right.
A very common misconception about neurosurgery in general.
Common misconception about neurosurgery in general. In terms of what? Well, just what kind of misconceptions there are, or
I'm not sure.
You think about anyone
that you've been asked before, or anything that you've encountered yourself?
I mean, certainly, even my own colleagues, not within neurosurgery, as in outside of neurosurgery, they always laugh. So we do joint ward rounds on all our trauma patients, on our spinal cord injury and our head injury patients, and they always laugh at the same thing, which is, I don't know why you bother. None of them ever get better anyway. So that is a big misconception, because I can name so many patients who we all thought that and ended up walking back into our clinic. And actually, I'll give you a really good example. We had an 11-year-old boy who was hit by a car, came in GCS3 with fixed dilated pupils, did a CT scan of the brain and then an MRI scan of the brain that showed the diffuse axonal injury. You can see blood in the brainstem, blood across the whole cortex of the brain, and we said, he's only 11 years old, give him a chance, so we put him onto the pediatric intensive care, full medical treatment. ICPs are very well controlled, never had any hemodynamic problems, but he never woke up. After a week of sedation, he was still GCS3, no changes. Repeated an MRI scan, and just multiple areas of infarct. So I sat down with the parents, and we had a 1.5 hour talk about the poor prognosis and the fact that he's never going to wake up. And the next decision really is, what do we do? Do we put tracheostomy in the hope that one day he may wake up, or do we say too much is too much, we should stop the suffering, we should pull the tube? And I'm not kidding you. I finished that conversation about 6:30 in the evening. 8 o'clock at night, my registrar calls me and says, patient's just opened his eyes. And this is about a year ago. He's now back at school. He does PE. He goes to PE lessons. He plays football. He plays cricket. He comes to my clinic and say hello to me. It's absolutely amazing. So you can never say never, truly, in neurosurgery. Miracles can happen, definitely. And that's the biggest misconception, that people think all our patients either die or become severely disabled. It definitely is not true. And then the question here is, what about synthetic nerve replacements? Don't know is the honest answer. I mean, if you look at the current nerve grafts that we do, so for example, if someone's got a facial nerve injury and we can graft this facial nerve, or if they've got peripheral nerve injury, sometimes we graft the peripheral nerve. Even if you do it immediately in the acute setting, so you haven't given the chance for Wallerian degeneration to kick in, and you do a really lovely microvascular repair of the nerve, you're still looking at maybe 10-15% recovery of function at the most. You're definitely not looking at anywhere more than that, and that's using natural patient's own nerve graft that is designed for that particular function. So if that doesn't work, I'm not sure how a man-made, artificial thing is going to be any better than nature's own, substance. And I always say this: the patient's own autograft, I think it's always the best. And another example is bone graft. So a lot of people like to use synthetic bone graft, and that can either be completely synthetic, made in the factory, or sometimes they use other animals or dead people's bone, and they crush it and they take the bone matrix from it and create a bone graft. And a lot of surgeons across the world uses it. They put it into cages, they put it into screws to improve fusion rate. But what I always say is, if you are going to be fusing a patient's spine, you've got the spine opened up in front of you. You've got bone in front of you. Why don't you just take the patient's own bone? So if you're doing a posterior fusion of the cervical spine, let's say, for example, you've opened up, you've put your screws in, but the lamina is not doing anything at all. That just sits there. You don't need it anymore if you put screws in. So why don't you take the lamina off, crush it down, and then put it back in as bone graft on the side and promote fusion? Why do you need someone else's bone or an animal's graft? So the patient's own thing is always better. Always stick with nature. So if there's a nature's own graft, why produce your own artificial one? That's the way I see it. How do we optimize it? To be honest, I'm not sure we have an answer. I mean, we've obviously been doing nerve grafting for at least 20 or 30 years, in terms of the modern technique that we use. And over the years, we've changed things slightly in terms of using different types of stitches, using different kind of donor site, obviously improving microsurgical technique because the microstrips are getting better. We can do perfusion scans and Dopplers and all sorts to improve, the postoperative physiology as well. And nothing seems to be making a huge difference, to be very honest. So I'm not sure we're any closer to a breakthrough in terms of nerve, replacements and grafting. Right, next question is, how do you mentally deal with the poor outcomes from patients after surgeries? With a lot of support is the answer, to be honest. We all make mistakes, and sometimes you don't make a mistake and something can still happen. So I had a patient who came in with a spinal cord compression from a degenerative disease. So he had a big osteophyte that was present on the spinal cord. And he had some weakness in the arms and legs, but not terrible weakness. Took him to theatre. It's probably the most straightforward anterior cervical discectomy I've ever done. Nothing difficult about it. It went as smoothly as a textbook would describe it. From an anesthetic side, it was also smooth. They had no issues with blood pressure support or anything like that. But when the patient woke up, he was completely quadriplegic. So he couldn't move his arms, couldn't move his legs, grade 0 power. Over the period of about 2 weeks, we repeated 3 MRI scans, none of which showed anything. There was no blood clots, there was nothing present on the spinal cord, there was no new contusion or injury to the spinal cord, because you always worry, have I done something to the spinal cord? Everything was normal. The blood pressure was normal, so you can't even blame the perfusion. We've done nerve conduction studies that basically just show that the nerves are not working, but it doesn't tell you why. So, we were completely baffled, and then we referred them to another spinal unit for a second opinion, and then a third opinion, and no one could work out the reason why. But ultimately, I have converted a patient who was walking into hospital to, basically completely wheelchair-bound for the rest of his life. Even though I can't say I have made a mistake, it's obviously as a result of something that I have done. And there's no 2 ways about that. And it is very difficult to deal with that. You go home knowing that you've made someone worse. And in a way, that's worse than having someone die, to be honest, because he's only in his 40s. He's now lost his job. He's got family that he used to support. Now the family has to support him. It's really difficult. And you can end up spending days and nights just thinking about it and not going to sleep, and it really affects you when you come back to work the next day, because you start questioning your judgment, you start questioning your own abilities to operate, and it really knocks your confidence back, and it makes you really grumpy, and overall it's just a really bad thing. What you really need when something bad like that happens is you need a lot of good colleagues, and I think that's the most important thing. What you don't want is colleagues who will point fingers at you, say, look what you've done, you're not good at this, you should not be doing this, or for the next 10 of these operations, someone should be supervising you because I don't think you're good enough to be doing this job. That's the last thing you need. You want them to be supportive, you want them to come to you and say, you know what, it's happened to all of us. If these things happen, next time you have one of these operations, just ask one of us to come along, more just to make sure mentally you're supported, and just from a medical legal point of view, we can document and say that we haven't just ignored it and pretend that it never happened. We're doing something about it. Having supportive colleagues and a family to go back to, who will also support you and know that you're going through a difficult time. that is actually what got me through it, and it's really important. And as I always say to my surgical trainees, in the UK, there are obviously certain cities that are more desired. So people want to come and live in London. They don't want to go and live up in Hull, for example. No one knows anything about Hull, and it's cold, and there's nothing that happens up there. But I always say to my trainees, actually, don't choose the location. Choose the team that you work with. If they have a really good team there and they're all a good laugh and you get on really well with them, that's much more important than working in what would sound like a prestigious center, but with loads of consultants who actually don't really care about the next consultant along, because they just want to go home, they just want to go and do their private work and earn lots of money, or they just want to be on TV and make a name for themselves. That's not what you want. You want a really friendly unit, wherever that might be. But that's the most important thing. Is there any other questions? How do you manage the work-life balance being a neurosurgeon? Yeah, like I said, it is just about having a very understanding family, a very understanding wife in my case, or husband or partner. It is very difficult, not just for you, but for the rest of your family, knowing that you say you're going to come home by 7 o'clock today, but they know that it's not really going to happen. That kind of thing. But like I said, being very organized, and the one thing that you all have to learn to do is how to say no. What you don't want to do is keep saying yes whenever someone asks you to do something. And that's very easy when you first start off as a resident or as a junior consultant. You feel like you need to prove something, that you're a friendly guy, you're approachable, you're here to help, so people like you, and you end up saying yes to this and yes to that. And before you know it, you've taken on too much that really just can't be done in a 24-hour period, and then you can't say no to it anymore. And people will keep coming to you because they know you've said yes before, so they know that you're going to say yes, but they'll give you more and more things to do. And it sounds horrible to say no to people, but actually you need to look at your own schedule and say to yourself what is realistic and what isn't realistic, and choose the things that you're actually interested in to do, and just have to say, I'm really sorry, I really don't have time to do this.
I've got a very simple question, to be honest, about what is the difference between two spinal surgeons, one with an orthopedic background and one with a neurosurgical background?
Good question. I need to word my answer properly to make sure I don't offend any orthopedic surgeons. No, to be honest, I think the biggest difference is our training is very different, and as a result, the way we think are very different. So as a neurosurgeon, for most of your training, you're dealing with the dura, you're dealing with the brain, the spinal cord, and the nerves. That's our friend. If I'm doing a spine operation and I'm doing a decompression, I want to find the dura quickly. Because once I know where the dura is, I know what's safe and what isn't safe, and that tells me how far I'm allowed to go. If you're trained as an orthopedic surgeon, you don't want to see the dura. That's the last thing you want to be seeing. You want to do as much of the bone work as possible. So if a patient presents with a disc prolapse pressing on the cauda equina or spinal cord, or they present with a tumor, you want a neurosurgeon who's used to doing the delicate work there. However, if you have a deformity, you've got scoliosis, you've got kyphosis, or you need some horrible en-bloc resection like the big sarcoma that I showed you, you want an orthopedic surgeon, because they can put the screws in with the eye closed and they will get it in the right place because they're so used to it. Whereas if a neurosurgeon is putting a screw in, they're probably taking about 20 x-rays just for one screw to make sure it's in the right place because they're not used to it. The other thing the orthopedic surgeons are very good at are biomechanics and sagittal balance. They will look at the patient's whole spine, they'll look at the sagittal balance, the coronal balance, they'll look at the center of gravity of the patient, they look at the pelvic tilt, where the hip joints are, and therefore where the spinal curve should be to make sure the patient's not falling forwards or falling backwards. When a neurosurgeon fixes a spine, they see a fracture, they literally put 2 screws above it, 2 screws below it, and put 2 rods on, and job done, is fixed. But they don't actually look at where they fixed the spine. And I had a patient who came to me with a horrible cervical spine fracture, and to be honest, a good fixation, But the patient came to see me because the patient couldn't go up and down the stairs. And the reason is the surgeon who fixed his head and the neck fixed it in a slightly extended position, so the patient can't look down. So he really struggles to go downstairs because he can't see where the hell he's going. And that's part of the problem of the neurosurgeons not looking at the bigger picture and just sorting out that little bit in front of them. Whereas the orthopod will think about that. And so that's the biggest difference between the two. So I think it depends what condition you're trying to treat, and you should choose a slightly different specialty what you want. But most spinal surgeons nowadays, I have to say, are trained by both. So you'll come through a training program for one or the other, but you will always end up doing at least one, if not two, fellowships in either cross-specialty spine unit or in the other unit, just so you learn from the other side as well. And I think that's the best thing to do. And then here's a question. Oh, one question was missed, was it? What countries or hospitals would you recommend for neurosurgery electives? Okay, so I did my elective in Japan, in Tokyo, in a hospital called Tikei University Hospital. I thought it was fantastic. The doctors there were really, really friendly. I mean, like extra friendly. I arrived a few days early because I wanted to travel around a little bit, and the professor for the department basically emailed me beforehand and said the accommodation is not ready because we're not expecting you until this day. But for the first week, just come and stay with me at my house. And then gave me a set of house keys and just let me stay there. But they're really nice people. They do a lot of quite high technical work because they are quite far ahead of many other countries, as you can imagine. So it's a really good place to go to. So I really liked it. The other good places, obviously, in America. America's got some very good neurosurgery units. Penn State is very good, so that's Pennsylvania. Penn State, they've got a set of very friendly surgeons, and they do a very broad range of neurosurgery. They're not subspecialized in one thing. So a lot of people, want to go to the big names like, Michael Failings in Canada for spines, and go to Spetzler in America for AVMs and aneurysms. The problem with that is, because they're so famous, they usually have about 5 fellows, clinical fellows, 5 research fellows, and another 5 residents, all crowding in theatre trying to see something. And as the elective student, you'll be the one shoved out the door because there are too many people in theatres. You don't want to go to a really big unit like that because you actually don't end up seeing as much as you want to see. You want to go to a friendly, slightly smaller unit that still does everything, because you just want to see everything and potentially even get involved. And when I was an elective in Japan, I got to make my first wearable as an elective student. That's what you want. And certainly, I don't want to boast about Imperial, but you are all very welcome to come to Imperial. I'll be very happy to host any of you here, obviously. And you're very welcome to come to all my operating lists and see as much as you like. And that's a given. Right, what else is there? Do you think doing a BSc in neuroscience is essential? I don't think it's essential. I do think it does help. Once again, like you said, in terms of commitment to neurosurgery, does it really help in terms of actually becoming a neurosurgeon, as in from a clinical point of view? It probably makes no difference. I mean, I did a BSc in neurosciences. I learned all the molecular basis of an NMDA receptor, with the alpha and the gamma units and the cyclic AMP and cyclic GMP. Does it really help me be a good surgeon? No, not at all. Do I really need it? No. Completely forgot to know mostly about it, to be honest. Unfortunately, it's something that goes on the CV, and it does give you the extra point when you go for an interview. So from a portfolio point of view, yes, it gives you an extra point. But from a longer term career progression point of view, personally, I don't think it's very useful unless you actually find it interesting, or you want to become an academic surgeon and you're interested in research work, then yes, of course. Any other questions from anyone?
I don't see any other questions. I think we're running a bit over time.
Okay.
I think you're in the hospital as well.
No problems. Well, in that case, I'm going to leave you guys to it and catch up with the on-call team and find out if they need me for anything else. Thank you very much, everyone.
Okay.
Thank you for inviting me. Best of luck to all of you.
Stay positive and test negative.
Yes, exactly. And if you have any questions, you can find me on Twitter. Okay, take care. Thank you very much.
Thank you.
Thank you. Bye bye.